So, Anas, why don't you go ahead and introduce Jay? I think we all welcome you all to this international symposium on medical retina by the Ordinary Ophthalmic Society. We don't have a chairman at this point of time, Dr. Natarajan and Rishi. They should be joining us very soon. I hand over the mic to Jay to introduce all the speakers and start the meeting.
All right. Thank you, Dr. Arora. Are you able to see my slides?
Yes.
Perfect. I'm Jay Chablani from Pittsburgh. Many of you know me. I'm the moderator for this session, and this session involves only the case presentations, and we would love to have questions from the audience. We do have very interesting cases, but if people want to share their experience through chat, feel free to do so, and we would be happy to get the questions. Let me go ahead and introduce you to the speakers for this session. We have Judy from Wisconsin. We have Rishi Singh, who will be joining us in a few minutes from Cleveland Clinic. We have Caroline from Tufts, Boston. We have Anand Rajendran from Arvind, Chennai, and George Manayat, a very essential part of all medical retina symposia in India from Arvind, Coimbatore. We have Dr. Lalit Verma, who will be joining us very soon because I'm sure he's busy in another session. We have Mona ma'am from Shankar Nethralaya, again, a very essential feature in medical retina field, teachers to many of us. Dr. Raja Narayan from LB Prasad, he'll be joining us soon. And we have Anirudh Maiti from Sushruta Eye Foundation, Kolkata. I have not spent too much time in introducing the speakers just because it would take 1 hour session. So without wasting any more time, I would ask Judy to get started. Hey, Dr. Natarajan.
Yeah, no, me and Rishi are still completing the previous session.
No worries.
We'll join back in a few minutes.
I know you guys are super multitaskers, so we thought we will give you a break.
Yeah, sure. So, okay.
Yeah, sure. Judy, you can start the nice case. Thank you so much. Thanks.
Welcome, Judy.
Thank you. Great to be here. Hello, everyone. Wherever you are in the world, good morning, good afternoon, good evening. I'm just excited to be part of this wonderful symposium and be amongst great friends and colleagues from around the world. I have a case that will start as unknown, but I think many of you will get to it. But it is something that we here, at least in the United States, are beginning to talk a lot about. So this is a 54-year-old woman who was seen by a general ophthalmologist first for her complaint of central scotoma, metamorphopsia, and yet she had 20/20 vision. And at that time, she was diagnosed with dry macular degeneration. But because of her symptoms that were not correlating to her retinal findings, she was seen by a neuro-ophthalmologist, and she was at that time complaining of enlarging blind spot. But then the neuro-ophthalmologist saw the retinal findings and then said, something's not right. So she comes to me. Well, this is what I saw when I saw her first. There was definitely areas of what appeared to be a geographic atrophy with drusen-like deposits, yellowish deposits. And it's very interesting that it's somewhat symmetric in both eyes. And there was also peripapillary atrophy in both eyes. And this is the OCT finding. You do see the areas of atrophy perifoveally, but the fovea itself is spared. So perhaps that's why she has 20/20 vision. But some of you might say, oh, wow, that sort of looks like the flying saucer sign that we sometimes see in certain conditions. So you sort of keep that in mind. And then this is fluorescein angiogram. So mostly a staining defect. Nothing was really leaking per se. This is autofluorescence, fundus autofluorescence, which I thought was quite striking. There was large areas of atrophy, hypoautofluorescent, but then this hyperautofluorescence was pretty much throughout the posterior pole, and it was very confined to posterior pole only. And indeed, she did have areas of visual field defect paracentrally. Her complaints of scotoma were validated. So what's going on here? So,
Judy,
yes.
I think it's really interesting when you go back to the autofluorescence. If there weren't those areas of geographic atrophy, you would think this was a pattern dystrophy. And, you know, maybe not exudative AMD, but some sort of dry AMD mimicker without those big atrophic areas. I would say, oh, this is a pattern dystrophy, and I would ask about a family history. But the one thing that you pointed out that is really interesting is when we see something like a pattern dystrophy or something genetic, both eyes are usually mirror images. They're very, very symmetric. And these are actually, they're not mirror images. They have the same pattern in each eye with a spot up to the right and a spot down to the left, which is kind of atypical, I think.
Yes, so I think that's what many of these eyes were initially diagnosed pattern dystrophy. Many of them are seen in inherited retinal degeneration clinics as a result, just as Carolyn said. So this patient has pentasen polysulfate sodium associated pigmented maculopathy. And these patients have interstitial cystitis, and she herself had been on PPS for 15 years. So what is PPS, or Elmiron? It's a trade name. It's a second-line oral therapy for interstitial cystitis, or otherwise it's known as painful bladder syndrome. These patients have urinary urgency. Sometimes they have to go 30, 40 times a day, and it's very painful and affects more than 1 million people, at least here in the United States. I don't know what this amount is around the world. And the drug, the medication, is analog of biologic glycose aminoglycans and binds to bladder epithelium. And it may be, people are thinking, that binds to RPE, retinal pigment epithelium, and causing toxicity. It was first used in 1980s and FDA approved in 1996. The usual dose is 100 milligrams 3 times a day, so 300 milligrams a day. But I've been seeing a lot of these patients, people have been on it for 600 to 800 milligrams a day. So the amount that's being used is not always uniform. There are some, but the eye problem has not been noted until 2018, very recently, by Dr. Jain at Emory. He saw 6 patients in his IRD clinic that had commonality, and that was pentasen polysulfate sodium. And then others reported as well, but this first one, median age of these women were 60 years old, but as young as 37. Median duration was 186 months, and there were alterations in RPE and photoreceptor. And as Carolyn said, many were misdiagnosed as pattern dystrophy, dry AMD, or other inherited retinal degeneration. And I had one patient I just saw the other day was even diagnosed with North Carolina macular dystrophy, and had even genetic testing done. And then there was a larger series with 35 patients from a multi-center study. And the median duration of PPS in this series was 15 years, median exposure 1,661 grams. Median age, again, ranges quite a bit, 37 to 79% years old. And I think multimodal imaging helps to document and also to diagnose. Color, I don't find as much helpful, but OCT does help. And these areas of atrophy are noted. And as I said, there can be flying saucer sign that we sometimes think of as plaquenil toxicity, but this also can occur in this condition as well. But I find the fundus autofluorescence to be most helpful, these patterns of hyper and hypoautofluorescence. And we can see that they can progress over time, and it's quite striking. And even after cessation of medication, it can progress. So I think it's very important that we diagnose them early before significant toxicity has occurred. So I present to you PPS-associated pigmentary maculopathy. It's a newly diagnosed that we should know, and maybe dose-related, maybe duration-related, but more needs to be studied. And I think the best way to diagnose is taking a good history, what medication, instead of just going straight to the eye, we should actually sit and ask the questions. And and even if they're not taking Almiron at the time, they may have taken it in the past. So I think it's very important that we actually recognize these patterns and then take good history. Thank you. Happy to entertain any comments.
Very nice.
I have a quick comment for you. So this is so important, and we've had some patients who actually haven't wanted to get off the medication because they really need this medicine. But in your community, have you notified the urologist or the internist about this potential side effect?
Yes, so I've sent to my hospital urologists and gyno-urologists who handle many of these patients. So they know that I'm interested. We haven't gotten to the point of actually making a screening mandate yet, but the word is getting out. And one patient actually came from a pharmacist because the pharmacist knew about this potential association. And there is a huge internet website about this potential Almiron toxicity among the IC patients. They have their own support group website. So
okay. I'm actually already in the link file. I had another webinar. I came early.
Dr. Jay, I would like to have a comment to Dr. Judy. Thanks.
Hi.
Thanks, Doctor.
I'm trying to mute Dr. Natarajan.
I'm here. I'm in the.
Jay, you mute.
I'm not unable to mute him.
Nati, can you please mute yourself?
Take your time, sir.
I think he's busy talking.
Yeah. Okay. Carry on.
Yeah, Dr. Judy,
Sorry.
thank you very much for sharing a good case, and it was a learning experience. I have a doubt. In your cases, the geographic kind of atrophy was very evident, but I couldn't see the typically described pigment spots or pigment clumps and the subretinal yellowish spots, interspread subretinal yellowish spot in the case, and also the pigment clumps or spots were also missing. Is it because it was a more advanced case that these findings are not seen very well?
So the color fundus photograph is not always best, as you know. And sometimes certain cameras pick it up better than the others. So the pigmentary changes are actually quite mild. Even though we call it pigmentary maculopathy, it's actually quite subtle. And then the OCT findings, it's actually, you do see some of that here, not only the atrophy, but at the edge, you could see some of these deposits between the photoreceptor and RP layer. So it's actually on top of the RP layer or within, actually definitely above the Brooks membrane layer. So I think they do, and they look different than drusen, where it's within the Brooks membrane. So it's, you look at abnormalities right above the Brooks membrane and RPE. And that's usually where the earlier cases you have.
Yeah, probably your OCT shows those focal, thickening of the RP nodular thickening, but I couldn't see those pigments on the classically shown in the literature. Probably, I know that this causal association is not yet sorted between the pentosan and the maculopathy. There is some confusion and about whether it is actually the causative agent, but when I saw that there is like a number of years as well as like 7 years exposure showed some 40% incidence of this maculopathy, and The dosage also, higher the dosage, 1,500 gram per day, had higher incidence of this maculopathy. So probably we have a causal association. Maybe larger studies would show whether it is really a causative. But then I found that there is some confusion about whether it is really a causative agent in this maculopathy. What do you say?
Yeah, I do think there is still a controversy, and I think we do need to study more. The important thing is that when we see the autofluorescence finding, which I think actually is the most helpful of the imaging that we do for this condition, that we ask. It is a very difficult conversation that we have to have with the patient. You know, they suffer quite a bit, and to tell them that you may have to stop this medication for the sake of not going blind, you know, it's always a risk-benefit ratio discussion, right? So it is a very difficult discussion to have, just like we have with plaque renal patients. The fact that these can continue to progress, and I've seen a patient that progressed over 6 months, sometimes it can progress quite rapidly depending on the stage of the toxicity, that we may be able to prevent them from losing their central vision by stopping it early. And I do agree with you that the jury is still out whether it's actually causative or not, because not everybody who's on high dose for many years end up with maculopathy. In fact, you know, I don't think the incidence of maculopathy from Almiron is as high as even plaque renal toxicity. I think it's actually not that high, but I think still it's worthwhile keeping our lights up there, thinking about it as we see these patients.
Thank you.
Caroline,
Thank you.
you had any quick Caroline, you had a quick comment?
I just had one more quick comment. If Judy goes back to her OCT, I know we have a lot of people interested in the choroid in this panel, and this patient has very thin choroid, and we might find that there are certain things that predispose patients to have this toxicity. I guess Judy will have to tell us next year.
Yeah, I think it's
we
would like to see the
soon.
biomarkers, right? You know, what kind of biomarkers predispose. Certain patients have toxicity while others have been on it forever and ever in high dose and they never have toxicity. So yeah, I think we do need to know, you know, whether it's a cumulative dosage, whether it's something related to their BMI, whether it's related to the choroidal thickness. I think there's still a lot more that we need to learn.
I think we should be moving on to the next case, but just I wanted to make a comment that this is something very serious because there are many lawyers and the law firms who are really hunting for the doctors who have prescribed this. And I had a conversation with our urologist, and overall, the fear is that, means you guys will be surprised if you Google it, it clearly says the doctors were aware of this toxicity and they still never informed you. And patients are really upset, and there are a lot of lawsuits going on this. So we really have to learn about this.
So
Thank you so much.
Can it be told prior hand before starting that you may develop?
Because, you know, Dr. Verma, we really do not have any conclusive causal relationship. So you will see that there is a recent JAMA editorial commentary which really questions the association and the long-term progression in spite of stopping the drug. And there are a few papers, I was going through the literature, and there are a few papers in the urology literature which questions this association. So we should be definitely saving our urology colleagues and not putting them into trouble, because this could be really dangerous to all of us.
Okay.
So I have a question here to Judy. When you have a patient like that, would you tell a urology colleague to stop the medication or reduce if the patient is on a very high dosage?
So we start the conversation depending on what dosage they're on and what their symptoms are. One patient stopped on her own without any of our input, because she was just afraid. And she said, I'll find some other way to manage my painful bladder syndrome. Others, because of their symptoms, they will go down to as low dose as tolerated. And others, the urologist will say, well, let's try something else before we do we come back to the Almiron. So I think, you know, it's definitely a conversation you have to have with the patient and the urologist, get them involved, and then decide what's the best way to control their painful bladder syndrome, because it's quite a debilitating condition.
Yeah. Let's move on with Rishi's case. Thank you so much, Judy. It was really nice case. Thank you.
Yeah, wonderful case. Actually, let me make sure I'm unmuted.
You are unmuted. We can hear you.
Oh, perfect. Okay, great. All right. Yeah, wonderful case, Judy. Actually, we published in ophthalmology a hypothetical mechanism based on basic science why that might be occurring. So that's a good, I think a good, we don't have a causal relationship, but I think your comments were spot on. So thank you for giving that talk. And I'm going to talk about not a diagnostic dilemma, but more of a therapeutic dilemma. And this is a long-term outcome for a patient with CSR that I managed. And this is his history. He's a Hispanic male. He was diagnosed with central serous in both eyes back in 2013. He has cataracts in both eyes, as well as visual acuity in the right eye is 2300. His left eye is 2025. On the OCT, you could see there's sort of a thickened choroid, maybe. There's sort of that stalagmite appearance where you see this material growing below the retina. You see subretinal fluid present as well. And interestingly, in the right eye, he had also these sort of deposits present here and subretinal fluid present with good vision in that eye. And so it's interesting. Jay and I have talked a lot and done. Jay is a luminary in the field of central serous. So this is like presenting to the gods of central serous, but it's more of a therapeutic dilemma than it is a diagnostic dilemma in this patient. Their fluorescein shows you just basically some leakage, which is in and around the fovea that you can see here. There's no real peripheral leakages and nothing that is really obvious from the standpoint of a neovascular component. Here's the left eye again showing you peripheral areas of leakage in this same patient in the early and late frames of the fluorescein angiogram. And so I just thought I'd open it up for comments to all of the panelists. You know, what is the role of OCTA in these patients? And do I really need an ICG in any of these patients? When looking at the case so far, do you feel like you need one for that? And why do you need one? And then I'll talk about the treatment options in just a moment. So let's open up to the panelists and see what their comments are about that.
So I think OCTA can be helpful in some of these patients, especially when you see that little elevation there, to see whether it's associated with choroidal neovascular membrane as well, because as you know, CSC can be associated with, some patients go on to develop CNVM along with CSC. So if there is CSC with CNVM, the treatment may be a little bit different than that without CNVM. So in that case, I do think OCTA can be helpful, but I do not think ICG is helpful. I don't usually use ICG for this type of cases.
Anand, any thoughts?
Yeah, I agree that, I mean, I would bring in OCT angiography if I suspect CNVM or a neovascular activity there. The course is not following the regular CSCR course. ICG, I now tend to do, fluorescein and ICG combined, so I do get them along. EDI, I think, really helps. I do not have a swept source OCT, so I rely more on EDI scans for CSCR. I'd like to look at the choroid as we all do.
Great. Great, Dr. Anand. So, the treatment options are obviously quite diverse now. Obviously, if there is anti-VEGF in the setting of CNV, then there's a rationale to use this. There have been some case series and reports using anti-VEGF in the setting of non-neovascular CSR, but probably the more important data has really been around PDT, eplerenone, and micropulse laser. PDT, obviously, in reduced and full fluence fashion, has been validated in a variety of different retrospective series, the largest one being the Macula Society study. Eplerenone was studied recently in the Vici trial, and I would love to comment on this study. I think this is probably the worst trial design for any eplerenone evaluation we would have done. In this study, actually, patients were treated with eplerenone versus placebo and taken off the eplerenone after having response. So after 3 or 4 months, they were essentially removed from the eplerenone, and then they were waited to see what the outcome was. And lo and behold, at 1 year, patients were, off of eplerenone and had recurrences of fluid, which is what we don't do in clinical practice. When we treat with eplerenone, we treat the entire time, and I'll talk about that in just a moment. And finally, micropulse or traditional laser in this patient is an obvious issue. Just to touch a little bit on the pathogenesis, this is really quite review, but I'll talk to you about some of the more recent advances in this assessment of the pathogenesis. We know it's due to possibly choroidal hyperpermeability that then leads to retinal pigment epithelial decompensation, then forms these pigment epithelial attachments, and you develop then a break in the RPE, and you develop subretinal fluid as part of that process. And that develops the neurosensory retinal detachment. Probably the more recent spectrum is this Pachychoroid spectrum that Billy Freund has worked so tirelessly on, where you essentially in Pachychoroidopathy, you get non-specific RPE changes, choroidal thickening, choroidal hyperpermeability, and numerous scattered elevations in the RP in the sub-RP area. And here you can see those RP elevations in a patient with fellow ICSR and those sub-RP like drusen deposits in this patient. Again, the question I think in this case is why these patients develop choroidal hyperpermeability by ICG. And I think I have some recent data to show you that would show you why that is the case. In central serous, you'd obviously develop those RPE changes, the subretinal fluid with the serous PEDs, and you get this gravitational fluid, which is probably the pathognomonic case. And obviously in the late stage form is pachychoroid neovasculopathy, where you develop type 1 sub-RP CNVs, lipid and heme on the actual evaluation, and then polyps on the ICG. And probably the more recent data is this one. I don't know if you all saw this presentation, but it was a wonderful presentation given by Rick Spade at the Macular Society. None of the Macular Society was able to broadcast out. But what he showed essentially was, Hayray had shown us for a long time that that they're vortex vessels, and that the ICG, if you look at these watershed zones, essentially the macula is the watershed zone or between these vertical and horizontal vortex veins. And in CSCR, essentially what you're seeing, or CSC, you essentially see intervortex venous anastomoses. And so what the reference here is that essentially that you get these pachychoroid vessels or intervortex venous anastomoses because of the fact that you essentially have a developmental abnormality in these patients. That this is an abnormality actually of the venous choroidal architecture, which leads to venous congestion, just like you would if you had a patient, for example, with the veins that dilate in the patient on their leg or on their arm. When you see those varicose veins, essentially it's in a very, very similar way. It's venous congestion. And that causes increase in back pressure in the choriocapillaris and leakage in the choriocapillaris and finally damage. So I thought that was a very keen assumption. And he did this with many patients looking at these pachy vessels and intervortex venous anastomoses in the patient. And again, the treatment for these patients is quite difficult long-term because no studies looked this out. Actually, this is our paper from the BJO looking at 3-year data on patients with eplerenone. Most patients actually had their anatomical response at year 1. And this is why I criticized the Vici study. I don't think it did what it should have done. And all of these patients were continued for 3 years on eplerenone therapy. While we didn't see a significant improvements in visual acuity, we didn't expect to see that because of the fact that they had good vision on entry and they had good vision on the end of the study. However, the anatomy was significantly improved, and they resulted in far less evidence of patients with subretinal fluid or of the height of subretinal fluid, even the greatest linear diameter. So really quite a good situation. Now, this is just the patient I treated in this case, and I decided between eplerenone and PDT, and I'd love to hear the panelists kind of think about this when I finish this talk and show you these last few slides. But essentially, I chose PDT because of the chronicity of this patient's fluid and the visual acuity drop-off that I was concerned about. And I did a PDT in this case. Here you can see the 1-month PDT follow-up. Again, the spot size for this, I have determined to be basically on the areas just to cover the leakage points, nothing more. I don't cover the the actual PED component. I just cover the areas of leakage. And I've done that in this patient with reduced fluence PDT with quite a nice improvement in actually the OCT. But you can actually see on the IR image how much atrophy you have present in the fovea. Their visual actual improved to 20/80. This is actually now a year later. And this is actually even to 7 years later after their initial treatment in 2013. They're 20/80 in this right eye. Again, showing you a nice improvement in that subretinal fluid and no recurrences, not one more additional treatment of PDT here. And this is the right eye post-treatment, again, showing you 2021, just recently that came in to see me 20/80 vision in the right eye. And this is the left eye, again, with that subretinal fluid. Again, reduced fluence PDT was applied, and you saw an improvement in the subretinal fluid. And here again, you see by 2021, the patient now 7 years after treatment has not received an additional treatment modality. So I just point this case out because I think it's important to show you that obviously there are a lot of options to treat these patients with. Probably they're very tailored to each patient's approach. And PDT is one of those things where it's not readily available, but if it is, it can be very effective. And certainly it obviates the need of continuous eplerenone therapy potentially in those patients as well. So I just thought I'd bring that case up, and I'd love to hear your comments about what your thoughts are on managing these sort of chronic patients.
So Rishi, you said because this patient was chronic, you chose PDT, but if it were not chronic, would you have chosen other different treatment otherwise?
Yeah, I think I mean by chronic in the sense that, Judy, there's some obviously outer retinal architectural significant changes in this patient where they've lost visual acuity and photoreceptor loss. Their lip side zone is totally destroyed or at least affected by this condition. If it was more intact, I probably would have chosen eplerenone earlier in this case. And I only chose, by the way, I only choose any of these therapies in chronic conditions. Chronic meaning greater than 4 months is defined by many of these trials and studies. But I think that the issue is looking at the outer retina, determining what the best course of action might be for this patient. This patient obviously has chronic damage and loss of visual acuity. And so I wanted something, in this case, that eliminated the fluid a little bit more. In my hands, at least, I feel like PDT eliminates the fluid faster and restores the outer retina faster in these cases.
So my definition of chronic is actually about 6 months, but I do see them in between to make sure that it's actually improving. If it's improving, then I continue to wait. But
I'm so happy to see that
half fluence PDT works really well. For me, that's the way to go. It's one condition where PDT works like a charm. So I usually end up with the half fluence PDT for most of the CSC cases.
Rishi, in case if you don't have the PDT for some reason, the verteporfin is not available sometimes here. And then do you recommend eplerenone, or what do you do about it?
So I've used spironolactone, I've used rifampin, I've used eplerenone. I've had the most experience with both spironolactone and eplerenone. Those are both eplerenone is pretty readily available. It's a potassium sparing diuretic. But spironolactone is available. The only issue I've seen with spironolactone is I have seen gynecomastia in men. I've seen it twice. And so that's why I shy away from using eplerenone mainly in the male patients.
Jay, I think I just want to bring, we have done along with Jay also as part of the study, we compared a head-on trial eplerenone and PDT, low fluence PDT, and it just come out in European journal last month. Long-term results after 1 year results post eplerenone and post PDT. And we found that with single sitting of, as Dr. Judy rightly mentioned, we found that the people who were subjected to low fluence PDT one sitting had no recurrence at all in this long-term results. And people who were if you read that article, we have completely given 6 months, not like VC trial. All of them received eplerenone standard dose 50 milligram for 6 months. Whether they responded, not responded, they were for 6 months. And then either patients who did not improve were lost to follow-up, or patients were withdrawn if it was a non-responder. So we found that it is far, far superior to eplerenone. Just wanted to add.
No, I think it's a great, I think, again, these studies, and Jay has done so much work here. Every time I go and look at, it's like Jay Chablani has all these lectures given on this sort of topic. So, I think it's a wonderful area to look at, but the issue is, I think, long-term, even 6 months. So in your trial, you randomized patients to receiving just 6 months of therapy, or did you continue it all the way through?
No,
Because
patients who responded were continued, and patients after 6 months who did not respond, they were not on the treatment anymore.
Yeah, so that's what I think that BJO article shows you, is that even patients at 1 year responded finally. And I think the timelines are slower, obviously, with eplerenone. I'm not saying it's the best drug. I think PDT is far superior. But I think that using eplerenone longer can actually make a difference as far as that.
So Rishi, one small query I had, excellent presentation. I also have a similar experience with PDT as well as eplerenone, what George was saying. But one question which keeps bothering me is, what is the role of verteporfin in this? Because verteporfin in ARMD binds to that lipoprotein receptors we know and enhances the laser uptake. But what in CSR? Why?
So that's a great question. So again, if the choriocapillaris has defects within it, that's all we're doing essentially, is we're not treating anything other than maybe the smallest choriocapillaris leak potentially. Or maybe if those vortex vessels that I just showed you, as Rick Spade adequately pointed out, if we're stabilizing them in some way, shape, or form with the PDT treatment, that would be the other way of saying that's working.
So
but you're absolutely correct.
What is supposed to bind at that receptors?
It's supposed to bind. It's supposed to essentially leak into spaces where it's not supposed to bind to receptors per se. It's supposed to leak into newer neovascular vessels, but it also essentially can find a leakage point. So, for example, you don't do PDT in a diabetic patient, as an example. And that's because of that the amount of permeability they would have in those cases.
So will this laser work without the injection of verteporfin?
No, I don't believe so. I don't think I've ever tried. The laser obviously is light activation to the verteporfin to actually change in configuration and block the vessel. That's actually what it's doing. But I don't believe it will work without any laser application.
No, without
I think, Dr. Verma, I think we are eating away Caroline's time.
Yeah.
I think that you all are able to see the timer, right? So we will certainly come back to this, and I have been dreaming about having a CSR meeting for the whole day, and we can certainly talk about this. Thank you so much, Rishi. It's always inflammatory topic, though there is hardly any inflammation. Thank you so much. And let's move on with Caroline. Caroline, you need to unmute yourself, I guess.
Can you hear me? I think
yes,
I'm unmuted.
Very well.
Okay, perfect.
Very well.
So, well, we can continue to talk about the choroid with my case if you want, because I'm going to be talking about a solitary macular choroiditis. It's a little long, so I'm going to kind of whip through the history. This was a 60-year-old white male who presented with decreased vision in the left eye for 1 month. There was really nothing significant in the past ocular or medical history. The systems were negative, and I'm going to show you the pictures here. The right eye was normal with 20/20 vision, and the left eye was 20/60 vision. And these pictures are from the referring doctor. And that's not blood in the macula, that's some pigment change. Everything else was normal, no vitritis. So we see this subretinal white lesion, left eye. Here's the fundus autofluorescence. Again, the right eye is normal, so I'll just tell you that to make it easier. Left eye, we see some pigment mottling. And this patient was not on eplerenone, Judy, just in case you're wondering. And let's get to the OCT, because that's always, where we see a lot of stuff here. And now we can see that on OCT, the choroid is thickened in the left eye where this lesion is, and it looks different. This is an OCT from almost 10 years ago, but it looks packed, it's thicker. We don't see the choroidal structures like we did in the right eye. And we can see there's also a little bit of subretinal fluid and a little bit of kind of thickening of the RPE. So does anyone have any thoughts? Anyone want to throw out a couple potential thoughts at this time?
Anand, any thoughts? How would you look at this patient in India? I think Anand is not here.
Okay, no problem.
Any other thoughts, anybody?
Yeah,
What would
I'd
you
just like to, may I say something?
Yeah,
Perfect.
please.
Yeah. Uh, this is a very superficial granuloma. I'm sorry, please, somebody else take over.
No. Rishi, do you want to speak?
Yeah, I was going to
this?
say there appears to be a choroidal lesion of some sort. If you go back, the markings in the choroid are very indistinct. If you go back to the OCT picture, I would expect if you thought it was a vascular component, that the choroidal markings would be much more enhanced. But here you can see density there, and so that's concerning to me. And I have a very famous another Singh in my clinic, Arun Singh. So I'd probably refer this patient out as soon as possible to Arun Singh. But Carolyn is a jack of all trades, so she'll probably tell me something different.
Okay, so here's the fluorescein. We see some modeled early hyperfluorescence leakage. It is kind of interesting that the nerve is hot, but I love this ICG because it is like no flow. It is black in this lesion. So at this time, our differential included lymphoma, granuloma, atypical choroidal osteoma. I always think about lymphoma and these strange lesions. And we did a workup and everything was negative. The patient was followed closely by their outside physician. But the patient was sent back because the lesion started to grow. The vision was stable, but the lesion started to get larger. Here we can see now the OCT at this time. We have a better OCT. We can see the back of the lesion. The subretinal fluid has gone, but we can see the thickness. And the B scan showed some diffuse choroidal thickening. Does anyone think this is scleritis? Maybe, a little atypical, but the nerve was hot. So this patient was followed for this slowly enlarging macular choroidal mass. We had this differential and the workup was repeated. Everything, including quant gold, chest CT, everything was negative. So the patient was put on prednisone. Of course, knowing that whatever this lesion is, obviously this lesion appears to be active. So if it's a granuloma, it can respond to prednisone, but of course lymphoma can also respond to prednisone. The patient was put on prednisone and the lesion got smaller. However, the patient did not like being on prednisone, had a lot of systemic side effects and wanted off. So the patient was taken off prednisone and then the lesion started to regrow with reduction in vision. The patient went back on prednisone and then the lesion continued to grow. And so is anyone ready to stick a needle into this lesion? Anyone ready? Right in the macula? Anyone ready? By the way, the patient had repeat chest scan and a gallium scan. Everything's been negative.
Well, I think even prior, Caroline, even prior to the prednisone, you can put it's probably easier to do a fine needle aspiration in this patient from that. And you're in the posterior pole, I know, but under direct visualization, I've done these cases before where you can actually aspirate some material here very easily with fine needle aspiration. I mean, that's been a readily way of doing that sort of analysis, biopsy of that area.
Well, this patient had a fine needle aspiration and it came back granulomatous, inflammation, calcific, no evidence of malignancy. So we have some reassurance about that, right? That felt good. So the working diagnosis was a calcified granuloma or an osteoma, and the patient did fine after surgery, but it's not going to end there because the lesion continued to grow. And if you can see under the infratemporal arcade, there's satellite lesions, and this lesion is continuing to grow, and now the vision is count fingers. In between this time, the patient had subtenons cataloged. Right in the middle of February 2016, there was a small little cyst, and there was some new subretinal material, and the patient had an Ozurdex and actually improved, but the vision was still poor. The patient really did not want to be on oral prednisone. Then the patient came back with a retinal detachment, a MAC-on retinal detachment with a large break, and had a vitrectomy with gas. And the patient, we can see on the right, is the postoperative reattachment. And still, this lesion is growing. So the patient came back again, vision all dark with a bolus detachment and PVR. And this is really where we get to the crunch of the matter. Remember, this patient's already had surgery twice. He had a biopsy and he had one vitrectomy for a retinal detachment. And so the patient came in with a PVR detachment, and the resident is prepping the patient for surgery and doing the vitals, the heart rate, putting a stethoscope on like an ophthalmology resident does right in the middle of the chest. And the resident said, this patient's heart rate is really, really low. So low that we had to take the patient to the emergency room. And this kind of gave us the key to what was going on. So the patient was in complete heart block and wasn't in their previous examinations with a heart rate of 30. And the patient was sent for a repeat chest x-ray. Remember, this patient's had x-rays before and also had chest CTs before, but the patient had findings on the CAT scan that are very, very typical of cardiac sarcoidosis. So it is most likely that this was a sarcoid nodule in the eye. And it's interesting because I've read about cardiac sarcoid. It can actually develop in about 20% of people with sarcoid, and it's very underdiagnosed. And it's recommended that any adult who is below 60 that has heart block should have a chest CT looking for cardiac sarcoid. And this man had had multiple x-rays and gallium scans, and everything had been negative, and it kind of just manifest at this time. And by the way, this patient's systemic was repeated at this time. Everything was negative, but supposedly this finding of calcified in the septum is very typical of cardiac sarcoid. Right there, gadolinium enhancement of the posterior septum with scarring, typical for sarcoid. So I just thought this was a cool case because it's unfortunate that the patient lost vision and even lost at times being on steroids, but the systemic manifestations of cardiac sarcoid presented many years later, and it was life-threatening for this patient. So the patient had an ICD, was put on prednisone and transitioned to other immunosuppressives, then had retinal detachment repair with oil, and had a more targeted sarcoid systemic evaluation. So cardiac sarcoids underdiagnosed in about 25% of autopsies of people with sarcoid. As I said, the recommendation to screen all patients with heart block. And this is something that's important to catch up because it is treatable with a pacemaker and immunosuppression. Anyone have any other comments of, these cases can be really hard. These granuloma, lymphoma cases can be difficult to work up, especially when the patient doesn't have all the findings in the beginning. Any thoughts on this?
Excellent case. Excellent case. I was wondering that if we were seeing the response to prednisone was good, but the patient was not willing to continue on prednisone, should we have considered immunosuppression at that point of time? Because, if this patient comes next time, what do we do? So do you think that, would you consider immunosuppression next time when you see a patient like this?
I think the hard thing is that until the patient had the biopsy, it wasn't clear exactly what we were treating. I mean, It would have been nice if the biopsy showed something that could make you say, yes, for sure, this is sarcoid, but they didn't get that. I mean, it's right in the posterior pole. They didn't get a big piece of tissue. So I guess, yes, the patient could have had immunosuppression, but the patient really didn't want to be on prednisone and probably didn't really want to be on immunosuppression either. These medicines have so many side effects. And I guess when you say, well, now you have to be treated or it's your life, then it makes a bit of a different kind of thing.
I'm more interested to hear someone from India. How would have they managed this case?
Yeah, Jay, can I come in? Yeah, so
Yeah,
I mean,
please.
we know, at least in India, that, apart after tuberculosis, probably sarcoid is one of the greatest mimickers, and we're never surprised when we are hit by these kind of, oddball cases. Just on a tangent, I just like to add that in this COVID period, since we're doing a lot of screening for CT scans, what I've heard from some of my radiologist friends is that they're seeing this kind of appearance which Dr. Caroline has put up. That screen bud kind of appearance, they're seeing a lot. And a lot of them, when they send back to their ID specialist, they are coming back with the diagnosis of silent sarcoid. So it's not surprising that this is happening, and it's a very silent, stealthy kind of disease. And it's fantastic that you put up this kind of a case to show us how silent it can be, even in the eye. And it's just something that I wanted to put up, that with this wholesale screening which is going on, people are picking this up, especially radiologists, and sending it back.
Jay,
Fantastic. Superb case. Srinivas, please go ahead.
one fantastic case, Dr. Caroline. I think Muna madam asked the same question which I wanted to ask. When most of these blood investigations had come negative, and would HRCT would be a clue, because it's a narrow beam collimated images what we get through HRCT. So would it be helpful in the beginning stage before we went in for the fine needle aspiration? Would it help in any way?
Maybe the patient had a chest CT before and a gallium scan. So I think, we usually think the gallium scan is so sensitive, but it's hard to know why, because he'd had intermittent bouts of prednisone. Maybe that suppressed some of the activity, so it wasn't picked up on some of the scans. I mean, usually you don't do a systemic workup like 4 times, like this man had so many workups. So I think maybe now, this was also started in 2013, so maybe some of the imaging would be better now. But I have patients of mine who have pulmonary sarcoid, but they don't have symptoms and they don't treat them. They don't put them on prednisone unless they've symptoms. Does that mean they're at higher risk for having something like this? I mean, probably.
Yeah, I think we always learn a lot when we look at retrospect of 4 years of story in 5 minutes.
Yeah.
Fantastic case. Thank you so much.
Very nice.
Excellent case, Caroline. If there are no quick comments, we will move
Jay,
on.
I have a small question.
Jay,
Just a
may I say
tangent
something?
from what Anand pointed out and what Carolyn said during this pandemic time. Has it been that, instead of using the systemic steroids, you tend to use more of intravitreal steroids in these cases? Or you said a patient responded well to Ozurdex.
Yes,
I think that the pandemic hasn't so much changed how I manage patients. Although I try to get everything done at once so they don't have to come back as much, but I would probably manage my patients the same way. But what it has changed is the efficiency with how I manage my patients in the office, moving them more quickly and not taking pictures if they're not necessary. But if I encountered a complex case like this, I'd still probably do what I usually do.
Okay. Muna ma'am had a question.
Yeah.
Do you want me to?
Yeah, wonderful case, Dr. Bowman. Really enjoyed it. A small clue from the OCT. I know it was 2013 when probably we were not doing it. But if you look at the OCT, the EDI OCT, it looks very quiet, the granuloma. You don't see fibrin overlying it. You don't see too much of subretinal fluid. Generally, I would take that as a clue to sarcoid. Whereas if it's a TB granuloma, then it tends to have a lot of fibrinous reaction and fluid over it. So this, what I like to call a quiet granuloma, is generally, I would think it's a sarcoid.
Great, thank you for that.
Great comment. Let's move on with Anand's case. Thank you so much, Caroline. Fantastic case. There are more interesting things than CSR.
Can you see slides, Jay?
Yes, please. We can hear you well as well.
Okay, so it's a pleasure to present this case, a 56-year-old male who presented to us with painless progressive diminution of vision of the left eye of 3 months, was a diabetic, hypertensive, and cardiac patient under treatment. Best corrected acuity in the right eye was 6.6, left eye 6.12, was a non-smoker, did not use steroids of any form, no similar illness in the past. Now, fundus examination at presentation showed dominant finding was macular subretinal fluid. Drusenoid changes were seen more in the left than the right eye. You can even call them pachychoroids. I'd like you to direct your attention to these faint but definitely discernible choroidal folds, and we'll talk about that and their significance in a bit. The OCT showed macular subretinal fluid in the left eye and peripapillary skytic intraretinal fluid in the outer retina. There's definitely pachychoroid in both the eyes. Fluorescein angiography ICG showed the hyperpermeable foci, pachyvessels on the ICG. No definitive classic CSCR leaks. Staining of the drusen and choroidal folds were also seen on the angiograms. We believe this was an open shut case of pachychoroid with left eye CSCR. Photodynamic therapy was done to the hyperpermeable foci. And 1 month post PDT, there was a very satisfactory resolution and acuity improved to 6.6. You can see the macular SRF as well as the intraretinal peripapillary fluid has abated. But surprisingly, 3 months later, there was a significant increase in the subretinal fluid, in the macula, in the peripapillary area. There was alarming optic disc edema, and vision had also marginally decreased to 6.9. And we believe we were looking at what was an incipient case of uveal effusion syndrome. So the fluorescein angiogram showed a florid disc leak, and the V-scan a very severely congested choroid. The axial length checked out to be, both eyes to be about 21 millimeters. Uveitic profile was normal. So we had no hesitation in calling this now uveal effusion syndrome. And considering that it was incipient UES, and there was this alarming choked optic disc, we went in with the injection intramuscular dexamethasone as well as intravitreal dex. And it was also based on the paper by Shields a few years earlier, where they showed a successful treatment of UES with steroids. The post-injection day 1 patient was symptomatically better and remained so for a week. But worryingly, subsequently, a few weeks later, patient's vision dropped to 6.36. There was progression of the UES, and with significant subretinal fluid, there was disc edema increasing. There was definitely increased choroidal turgidness, as you can see on the OCT. Exudative RD was seen inferiorly, peripheral almost 360 degrees choroidal detachments, leading up to almost imminent angle closure with rising intraocular pressures, mandating up to the point of YAG PI. So we had no hesitation now in offering the patient subscleral sclerectomy, which is the standard for UES. Patient opted to wait, unfortunately, and was lost to follow-up. Then when the patient did come 3 months later, we were delighted to note spontaneous resolution of this uveal effusion syndrome. This complete resolution, as you can see, of the SRF and detachment, an epispot retinopathy was seen almost. The vision had dropped to 660, but that was because of the cataract. And you can see on the ICG, these pachyvessels almost swarming up to the macular area and in fact culminating at that atrophic PDT treatment spot. So post-cataract surgery, the vision improved from 660 to 612, and the patient had been stable thus for a year. So the unique features of our case was basically CSCR morphing with uveal effusion syndrome, features of pachychoroid in the uveal effusion syndrome, and spontaneous resolution of UES, prompting us to offer a pathogenesis postulate that UES may lie at the extreme end of the pachychoroid spectrum. So most of what we know about the uveal effusion syndrome comes from the stellar work done by Uyama and colleagues, where they profiled the disease beautifully, looked at the management options, and gave us this great classification. So we believe that our case was probably type 2, maybe type 3. We didn't really get to do a sclerectomy, so we couldn't really make an absolute thorough assessment of the sclera. It was not very definitely taken on the imaging. Going forward, as we know, where the pathogenesis, the sclera and its impermeability is implicated alongside congestion of the vortex veins as fluid accumulation, and a dysfunctional RP pump leads to subretinal fluid accumulation, along with the mismatch between hydrostatic and choroidosmotic pressures. So why steroids? That's a valid question. So Shields in their paper in 2017 looked at 104 eyes, all of which were type 3 UES. 95% of them improved with steroids. through different routes. Only 5% went in for sclerectomy, and the mean axial length was about 22 millimeters, somewhat similar to our case, which is 21 millimeters. The role of steroids, the mechanism of action they suggested was reducing inflammatory factors and control of this transudation via membrane stabilization. So a few citers for this nexus between UES and Pachychoroid. Well, there's an interesting paper and stray reports have been there in literature, but this anecdotal report is a shot in the arm for this theory, where Venkatesh et al. Showed in the case of definitive chronic CSCR with a large PED with fibrin around that with inferior exudative detachment, they did not have CDs or disc edema, and therefore they did not call this uveal effusion syndrome. They just called it as chronic CSC with inferior RD. The axial length was 21 millimeters. Like our case, they went in for a partial thickness sclerectomy with mitomycin C, and they found beautiful resolution of the case. So short in the arm. And a little while later, George, my brother in arms for CSCR, will also show an excellent case, which is similarly, and I won't steal his thunder by talking more about it. But there have been more cases in literature, straight reports, which have added credence to this theory that UES and Pachychoroid may be linked. More recently, as Rishi has pointed out, the vortex vein theory promulgated by Spade and workers, and also by Matsumoto, as mentioned, in his Spade's paper, that the different forms of Pachychoroid CSC, peripapillary Pachychoroid syndrome, and Pachychoroid neovasculopathy. Everywhere in all these, they found that that the segmental nature of the vortex vein is lost. Anastomotic channels, which perhaps can be called pachyvessels, they trespass the sacrosanct horizontal watersheds. And these anastomosis in CSC and PNV are obviously seen intuitively more in the macula. PPS is obviously around ONH, and the increased adjacence leads to CSR. And what we suggest is possibly a harbinger of UES. Vortex, as I mentioned, congestion is central to the pathogenesis of UES anyway, and decompression of the vortex is anyway one of the theories which were offered. Our case, as you can see, as I just like to reiterate, we could see the swarm of pachyvessels or anastomotic channels coming from the inferotemporal vortex vein system, and perhaps anastomosing with the supratemporal one. So in summary and points to ponder, in our case, setting was a predisposed eye, 21 millimeters, typical pachychoroid, but importantly, there were choroidal folds to be seen. CSR was there with choroidal hyperpermeability, responded well to PDT for a month, then slowly developed disc edema, UES, and subretinal fluid with good vision initially, 6/9, which prompted us to do that steroid trial based on the Shields paper. Was fine for a week or so, and then unfortunately over a week developed full-blown UES with CDs and inferior exudative RD, subscleral sclerotomy advice, but not done because of lack of follow-up. Spontaneous resolution was fortunate to be had. And we believe the supports the pathogenous postulate that UES may lie at the extreme end of some pachychoroid cases. And what we believe is that there are learning points to be had, that in a case of pachychoroid, 3 things need to be looked at. 1, short axial length, 2, choroidal folds, and 3, on the ICG, vortex veins. So these should raise red flags and suggest that this case of pachychoroid may slide down the pachychoroid spectrum, go through CSR possibly, and may even end up with uveal effusion syndrome. Thank you.
Fantastic, fantastic case, Anand. Well, why don't we actually get George's case as well, and then we discuss both the cases together, because they share a lot of similarities. Is that fine, George?
Yeah, that's fine. Fine for me.
Yeah. Sure. Go ahead and share, please.
Yeah, is it visible, Jay?
Not yet.
Not yet, George.
So Anand, by the time George gets in, how was the other eye in your case?
Yeah, the other eye was stable. It didn't show any increase in fluid or any form. It was kind of stable right through. Vision also didn't change, which was surprising and fortunate too.
Is it visible, Jay?
Yes. Now we are good. Please.
Can I start?
Yeah, please start. Yes, please.
Yeah, good evening all. Would like to look at this anterior choroidal loculation of fluid in central serous chorioretinopathy. So this is the first of the 3 eyes which we have seen with this finding. So to time constraint, we'll be discussing only the first case. And first case, 60-year-old male who is a diabetic, hypertensive, and coronary artery disease patient who has a best corrected vision of 660 in the right eye and 6/9 in the left eye. and he has immature cataracts in both the eyes. So the right eye shows chronic central serous features with subretinal fluid, interretinal fluids, thick choroid, and serous pigment epithelial detachment in his both the eyes. Here also you can see the thick choroid, subretinal fluid, and serous detachments. The fluorescein angiography at presentation was having diffuse RP epitheliopathy at the macula with few mild NPDR changes and diffuse leakage in the late phase. Both the eyes had the RP tracks and diffuse leakage at the macula in both the eyes. And with this, we made the diagnosis of chronic central serous with mild NPDR, and he underwent cataract surgery in both the eyes. And vision was 6/9, best corrected in both the eyes. 6 months later, he comes with a sudden defective vision in only in the right eye, and vision had dropped to 1/60, and he comes with a bullous fibrinous exudative CSR with inferior bullous RD, and he had this very exudation, thick exudation at the macula at that time, and he has peripheral choroidal detachment also. So this is the left eye remains the same. The serous PED and subretinal fluid and chronic CSE picture remains the same in the left eye. And this is a fluorescein angiography showing the blockage due to the thick fibrin at the fovea and the diffuse RP leakage at the macula with mild NPDR changes. This is a wide field picture showing the peripheral 360-degree choroidal detachments. And this is the montage showing the 360-degree peripheral detachment, inferior exudative RD. And also the ultrasound showing the inferior serous CDs with inferior exudative RD. So the left eye remains the same, mild NPDR and diffuse RP epitheliopathy leakage in the late phase. Chronic CSE picture remains the same. So we did a low fluence PDT multi-spot technique and treating the entire area of diffuse RP leaks. And you can see here the subretinal fluid started reducing by 1 month, and the fibrin started organizing under the macula, and the CD height of the peripheral CD started reducing, and vision 1/60 to 5/60 now. And this is left eye also reduced fluid. And this is the right eye showing at 2 months, showing that the subretinal gliotic band is forming and the peripheral CDs have resolved now. You can see that only the inferior fluid pocket in the inferior periphery. There is no CDs at this point. This is 2 months post PDT. This is a picture 4 months post PDT in the right eye. Both eyes, there is this RP degeneration at the macula. The right eye, the subretinal gliotic band has formed because of the organized fibrin, and vision has improved to 6/18 in the right eye. This is the resolved fluid, and you can see the subretinal gliotic band that has formed in the dry macula in the right eye. The left eye, you can see there is still remaining subtle subretinal minimal fluid in the left eye post PDT. So here we consider the first diagnosis at presentation was idiopathic uveal effusion syndrome, but the bilateral multimodal imaging features of chronic CSE and on all the imaging modalities, as well as the absence of leopard spot fundus or fluorescein angiographic features, guided us to this diagnosis with chronic CSE. And as you know, the pathophysiology of CSE is unclear, but we all know that there is choroidal hyperpermeability. Whether this is secondary to the venous stasis, which has been discussed by Dr. Rishi and Dr. Anand also, or it is an inner choroidal ischemia as suggested by OCT angiographic studies, we don't know. But the recent ultra wide field ICG angiographic studies have shown that when there is a temporal, for example, in this case, temporal choroidal hyperpermeability, the dilated vessels track back to the congested vortex vein ampullae only in the corresponding segment. For example, here it is temporal, so both supratemporal, infratemporal vortex vein ampullae, probably suggesting that it's an outflow congestion in this kind of a chronic CSE setting. I won't say this has been touched upon by Dr. Rishi and Anand. This intervortex anastomosis that we see across the macula as pachyvessel also gives us some clue that there is vortex vein congestion in these eyes. So lastly, there is an entity on swept source OCT called posterior choroidal loculation of fluid by Spade and Ryan, which showed that when there is excess choroidal thickening beyond 400 to 500 microns of choroidal thickening, the fluid gets accumulated in the outer choroid like this, interdigitating between the Pachy vessels or the outer choroidal vessels. So when choroidal stroma gets saturated, fluid either comes under the RP as pigment epithelial detachment or like this posterior choroidal loculation, or Spade was suggesting rarely it could accumulate in the suprachoroidal space pre-equatorial, where the choroid is loosely attached to the sclera. So why atypical CSC here? Because the patient was already on follow-up for chronic CSC, and he had bilateral serous pigment epithelial detachment, diffuse RP epitheliopathy, and he had developed a fibrinous CSR, bullous CSR, and response to PDT was quite remarkable in this case. So I would conclude we have reported it's coming out next month. So atypical bullous CSC with anterior choroidal loculation of fluid and posterior choroidal loculation we have already seen and is well described. PDT seems to be a promising treatment in this rare variant of CSR, and multimodal imaging is the key point in diagnosis and differentiating from the other differentials. So thank you.
Excellent, excellent case. I had a quick question, because I'm sure a lot of people in the audience must be wondering that did you have an axial length for your patients? Or did you work
this patient had a normal axial length. I hadn't mentioned here, but then he had a normal axial length in both the eyes.
Okay, so are we saying this is a CSR with UES or an effusion in both the cases, or it is just a progressive CSR which led to this, or they all fall into a venous insufficiency or venous congestion theory?
Yeah, Jay, I just want to make a comment. Now, slowly it is coming to that in CSC, though we say the inner choroidal ischemia, that could be secondary to the choroidal congestion, and more evidence that vortex veins are also, as I showed in the ICG angiographic studies, showing that the vortex vein is congested. We all know that not only in CSC, but in uveal effusion syndrome also, we know that abnormal scleral thickening is there, and that is causing a vortex vein congestion. Probably in CSC, we don't have a vortex vein abnormal scleral thickening in all the cases, but then there is some overlap between these two conditions, because there is no typical CSC leak on fluorescein angiography in Anand's case. But my case, we had 3 eyes with this presentation, which is with bilateral CSC features. While the patient was on follow-up, they developed this bullous kind of detachment and fibrinous bullous detachment, and they developed CD. So I think there is an overlap, wherein one case the scleral thickening probably is amounting to the vortex vein compression. Here we don't know what is the real pathology in CSC.
So George, yeah, I'd just like to comment a couple of things. So one is in George, when you look at George's case, as well as if you look at the Ames case, which I highlighted, Pradeep Venkatesh's case there, both were CSCRs with inferior detachments, and they treated it with a scleral resection, whereas George treated it with a PDT. End result, both resolved. So it is very unique that in both cases, one treated it by treating it as a uveal effusion, the other one treated it as a CSCR. And the end result was that there was a resolution of both. Both had, significant detachment. Both had fibrinous content with PDs. My case did not have the PD, the classic PD. Perhaps if it had waited for some time, maybe the PD might have come out. Maybe we would have had a more classic blowout of the RP, and then it might have shown up more typically. So what I believe is that, all this is in a continuum. We now, as we are doing more wide field ICGA, that is where we are able to recognize. Now, even in my case, I don't have a wide field ICGA, and I couldn't really montage it, but I'm quite sure that, if we had wide field ICGA, we would recognize and reconcile most of these cases to somewhere in that time point continuum of Pachychoroid up to UES. So I think that is there. Then the other point about scleral thickness. Now, as you understand, even that is why I think Uyama's papers are brilliant, because 20 years ago, even with just 1 or 2 cases of type 3, he was able to put forward that theory that with those cases, sclerectomy may not help. And that is where it was good to have the Shields paper coming in with 104 eyes, where they showed that there's something else happening and steroids help. My experience with steroids in classic nanophthalmic eyes is it actually doesn't work. It actually, I have found it actually kinds of worsens. I've actually given cases steroids and I've seen uveal effusion in 17 millimeter, 18 millimeter eyes actually worsening. And I always thought that the water retention caused by steroids is what's happening here. So there are probably slightly different pathomechanisms happening between 1 and 2 and the type 3 uveal effusion syndrome where sclera doesn't make a difference.
Great.
So this is a really nice series of cases between Rishi's case, Anand's case, and George's case. As you're saying, it may be a spectrum that we are seeing with commonality of vortex vein congestion with or without scleral thickening based on axial length and other things. And sounds like the treatment of choice is to decongest, whether it's with PDT. Studies have shown that after PDT, CSR cases, the choroid does thin compared to pre-treatment. So again, showing that there must have been some decongestion. Steroid may be also decongesting, you know, as an anti-inflammatory, and then the surgical way is also decongesting. And maybe the wide field ICG may help us to be better selective about the quadrant that we may want to do surgery, possibly. And this is it's a little bit left field, but you know, the one, the right eye that had vision loss because of the fibrinoid deposit right at the macula, maybe we could have injected a gas ball, a small gas bubble or something, had the patient positioned so that it doesn't accumulate at the fovea, at the macula, but somewhere displaced somewhere else. But I think these are really all very interesting.
But giving steroid, because giving steroid in my kind of a case, I would never do, because it's like a chronic CSR and is worsened, and I don't want the other eye to develop a bulla CSR because of my steroid. So I would be really scared to give a steroid. But one of the 3 eyes, I've just presented one eye. One of the 3 eyes, I did a sclerectomy, but it never worked. Probably because no scleral thickening was involved. I don't know, but it never worked. And finally had to do a drainage, endo drainage, settle the retina and do a PDT, and it worked actually.
Yeah, so I just like to comment on Judy's and George's comment, and also reconcile this with Rishi's case. Now, if you see in my case, I had done a PDT to just those hyperpermeable areas. And what you also notice, which I slightly alluded to in a presentation, is that SRF in the macula went, but also with that, the peripapillary component, the skytic fluid near the disc, that also went. So this also seems to say, and the same thing in Rishi's case also, he did a PDT, but fluid all around went. So if you can just decongest or silence with pharmacotherapy, that hyperpermeable area, that seems to have some sort of a effect all around and decongest the entire system somehow. So even though we are applying the laser to just this particular area, there may be some mild irradiation happening around, and we don't know if that is helping in the entire system getting silent.
Anand, Rishi, and Jay, I just want to bring in here. I know I have been doing a yellow micropulse laser for this early cases of CSR, and I've been having fairly good results with the PDT not being available in our country. So in these cases, if you repeat a yellow laser after about 3 months, and sometimes even on a monthly basis, it's working very well. So we really do not know, as I think Lalit asked, what is votopolfin doing? If you can have a yellow laser working similarly, I think PDT can work without a votopolfin.
Yeah, I agree. I quick comment to that. I mean, I was holding myself back because of time constraints in the Rishi's case. He raised a question about yellow laser, and I think Jay also has experience. We have had very good results with micropulse subthreshold yellow IQ 577 for CSR. We have not had the same kind of experience with diabetic macular edema, which many people in the West, and I think Eduardo Mideta's group and all have had. So I think CSR, given the fact that we don't have PDT, Right now, chronic CSRs around the 3 months to 6 month time, I think it does well with yellow micropulse laser.
I think, Anand, the basic problem is calculating the sub-threshold dosage, and that's where the problem happens. You know, your fiber optic cable gets old, and you really do not know what the sub-threshold is, and
Exactly.
that is
Yeah, because it's an invisible burn. How do you paint the entire macula, as in my case? When you are not sure about, sometimes you don't know what is the threshold. So when that is the only issue, like bilateral diffuse macular leakage. Actually,
that is the reason, Jay. I thought that even TTT may work. I could do. You see, even TTT, because it's a longer wavelength we are talking, so that it's hitting at the choroid.
George and myself have done a lot of TTT, and we were waiting to get into that. But
no, now that vertiporphin is not available in India, so I
yes,
thought of
sir,
doing.
we have quite an experience. We have published also. Jay knows that. Like almost we have compared with PDT, and results were almost comparable in.
That's what. Yeah.
I think micropulse does work, and 577 at least in my hands has been working extremely well. And you know, people may deny it, but you know, we've been getting excellent results.
So the reason of my asking the question to Rishi was the same. What is vertiporphin doing in this?
Let's go back to Muna and go back to the pathogenesis. I think she has some interesting comments on that.
She had a comment to make. I think she was raising the hand.
Yeah.
Dr. Muna.
Yeah, a very nice case, both of you. Anand, when you saw the patient the first time, did the fact that there was those intraretinal cystic spaces in the peripapillary area raise a red flag that there may be something else going on?
Yeah, so it was definitely Pachychoroid.
Yes.
We noticed that, yes, it was a little bit of a sign, but it was so minimal. It was just in a few, maybe 5 or 6 vertical scans. And then there was obvious hyperpermeability. So we looked very carefully at that peripapillary area to see if there's something. And actually, if you see that OCT, which I just showed you, only a line scan, the choroid was not thickened around the disc. It was actually tapering down. It became thin. So we obviously didn't think we needed to do anything there. And anyway, one would be cautious about doing PDT around the disc in any case.
So peripapillary intraretinal fluid was common in both the cases. That was common in both the cases. And I think that we are working on another interesting paper with Rick Spade, where we are trying to bring in the peripapillary pachychoroid also as a part of the venous insufficiency or venous congestion theory, along with the space-related choroidal congestion, because nowadays, yeah. Go ahead, Rishi.
No, what I was going to say was I think that it speaks to the differential in presentation in these cases, and that the actual vortex, the intervortex communication could be in very, very different locations. For example, as you're saying, maybe in uveal fusion syndrome, the issue is that you have those intervortex vessels in and around the optic nerve. And maybe in these situations of CSR, it's strictly macular. And that might be the difference in location that results in the difference in phenotype that we're seeing. Ultimately, they look very similar in nature. They might be treatable with steroids to some extent, but obviously the location matters, I think, a lot, and where the watershed zone ends up being. Maybe that's the difference in all of these.
And we all the papers which have shown the vortex vein congestion everywhere, it is a supratemporal one. How often? What is the congestion or the dilation of the supratemporal ampullae in normal patients? Is it just because it is serving the larger area, or it is actually the pathology? So these changes patients were born with, or they were acquired changes. We have no information about these things. So we are yet to learn that whether these changes are acquired or some people are just born with these changes.
Absolutely.
Yeah. Any other quick comments? We have time for one comment.
Yeah, one query, George. I have seen 2 or 3 diabetic patients with the CSR-like picture and sudden onset of bullous RD. One of them had a peripheral choroidal detachment, and we did pick up a pigment epithelial rip. So I think that's one thing we need to look at. And peculiarly, they've been in diabetics. So that's just something I thought I'd share.
One more thing, in uveal effusion syndrome, even in literature, it has been shown that the OCT and enhanced depth OCT shows thickened choroid and even pachyvessels. That's already documented. So the OCT alone can be common to both these conditions if you look at the enhanced depth image.
That is very true. Choroid is thickened in many diseases. You can still see the pachy vessels, but not everybody.
And one entity is also described isolated posterior uveal effusion syndrome without peripheral CDs. So it's a great movie.
All right, excellent case. And now let's switch gears. We will come back to Pachychoroid in a while. Let's switch gears to diabetic retinopathy by Dr. Lalit Verma. Thanks to both of you, Anand and George. Fantastic cases as always. Thank you.
So after having an overdose of, I think, central serous, we move on to another common disease, which I thought we know everything. You see, I still believe that, I hope this is visible, Jay?
Yeah,
yeah.
We are good.
So I still believe that laser is still the mainstay in PDR. And we all understand when to do all this HRC. Without HRC, I do scatter laser, and even sometimes in very severe NPDRs also, especially if it is non-eyed patient. So PRP, pan-retinal photocoagulation or full scatter, long decades we have been doing this. But this is when, our thought process got changed primarily because of, pharma pressure of the companies that, once they compared in this protocol S with the ranibizumab and said that it is non-inferior to PRP. So this is one of my patient who had florid kind of PDR with a lot of non-perfusion here. So since this was very, very close to the posterior pole arcade, and so I did inject ranibizumab, and after that followed it up with scatter laser, and it did pretty well. I'm not sure whether repeated injections would have done the same or not. This was another patient of mine who had, you see the number of fronts at the posterior pole with a lot of non-perfusion. Here again, I gave the same biosimilar injection, which I very commonly do, front at the posterior pole, and again followed up with laser. This patient again had stabilization. So this is another young patient which I wanted to share and in fact ask. This patient I had seen long time back, and from 2018 till today, this young IDDM girl had good vision in the beginning. Then again for 2 years or so she lost to follow-up. Then she came with florid PDR in the beginning of last year, and vision was still maintained. If you see September 2026 by 9 vision. In between, I had done a lot of laser for this lady, and suddenly after 2 months of this, she presented with a combined RD, and then took her up for surgery. This was the story of the right eye for 2-3 years, and this similar fate was there in the left eye. If you see florid retinopathy developing very, very fast, and despite laser, this patient had again a combined RD and had to do a surgery here. In contrast, this was a patient who also was IDDM, and had the difference between that young girl and this gentleman was that intervention was faster, and both these eyes, you see left eye, right eye, recovered good kind of vision. The retinopathy was not so florid in this. So I'll just skip this video. So we all understand vitreous surgery in DR. We'll not go into this, but the indications which are becoming more commoner are combined RDs and macular TRD. The vitreous hemorrhage non-resolving we rarely nowadays get. So these are the post-ops, couple of patients. So outcomes have definitely improved with better quality machines and smaller gauge vitrectomies, preoperative anti-VEGFs, and even bimanual surgery. I still do once the fronts are sticky and stuck onto the posterior pole arcades. So what I wanted to bring out in PDR is that judicious use of all these modalities for the maximum benefit. Laser, I still believe that a good scatter laser, because have so many eyes where decades back laser has been done and maintaining very nice vision. Anti-VEGF created confusion by some people doing it as the first line of treatment. I still believe that it's an adjunctive role only, although studies, long-term studies also are available, shows non-inferiority, but issue is of repeated injections, cost, and multiple visits, etc. I do anti-VEGFs only if there are recurrent oozes despite laser with good vision, or there are posterior pole large fronts, as I showed in 2 of my patients with good vision. Because if you do dense laser there, then there may be fibrosis later on. Other thing is that these 2 patients taught me that early vitrectomy in such patients adds to the long, and don't wait for very long time, because you could compromise the ultimately visual results. Patient may not gain much. Prognosis has improved thanks to all these multi attacks which are available. Thank you for listening this.
Thank you
I
so
just
much.
wanted to ask about the panel about how do they approach? Do they still do anti-VEGFs repeated, or anti-VEGFs first and then lasers, or lasers alone?
Dr.
Why don't
Verma,
you
I just
start?
gave a talk in the other session about this too, so I can answer the question. I think the vast majority of people, at least in the United States, have not adopted anti-VEGF as the primary therapy for proliferative disease. Rather, we take a blended approach. 25% of individuals say that they have started using anti-VEGF as primary therapy for PDR. The problem obviously is compliance and return to the patient and not doing that. But I would say that everyone, I think most of us have taken, as you did in your cases, not a strict approach to using laser alone, but using an anti-VEGF, then waiting because we schedule these patients for laser and then doing the laser. And then if they have recurrences and bleeds and you don't have time to repeat the PRP, you can stabilize with an anti-VEGF and continue. I think the big finding from Protocol S, at least for me, was that when treating with an anti-VEGF, you didn't end up with massive tractional detachments or crunch syndrome, as they used to call it. I think that was really, really reassuring. Again, I would say that the patients in Protocol S were not high-risk PDR, though. So those were very different stages of PDR. So in the high-risk PDR patient, we might see a different outcome. But I think we take more of a blended approach for this whole matter.
Yeah, as part of the DRCR net, I agree with Rishi that these were not severe cases. There was definitely a little bit of a bias in enrollment into the clinical trial. Definitely not macular threatening traction detachment patients, for instance. And even though there is no clinical trial data, for whatever reason, US people are doing the blended approach. There is no clinical trial data to show that the combination treatment is better, but most people are doing it because of the lack of follow-up. I've been burnt as well. I start injecting with anti-VEGF, but then they don't show up. And then next thing I know, there's huge traction retinal detachment and other things. So there may be a benefit to combination doing with anti-VEGF first so that you don't get the edema, macular edema, and then adding PRP for more stability or durability.
Jay, I just want to add one point.
Yes,
Lalit sir.
please.
Sir, usually if we look into this protocol S and all these things, we use anti-VEGFs only when there's no fibrovascular polyps. But when I see your case, the girl who already had a peripapillary traction, the peripapillary fibrosis was already there. So I don't think in those cases anti-VEGF really works well. And the patient was 6'9" in that case.
Yeah, 6'9" she is.
Right.
So that was hesitancy of my intervention because she was working in a Google company, and
anti-VEGF will definitely worsen in those patients because even if we laser them or don't laser them, they usually tend to progress because of the poor control of the diabetes.
The anti-VEGF was not given to her. It was given before she came to me, was given to her before that. Yeah. So I agree, because once the fibrosis sets in, anti-VEGF may sometimes worsen the traction.
And I would love to ask the panelists, in these peripapillary tractions, how many of these cases usually they tend in for going in for the major CRDs as what Dr. Lalit Verma showed? Because most of them do well if the sugars are under control, but the peripapillary traction once develops and they develop the CRD, whatever surgery, beautiful, fantastic surgery we do, but the visual improvement will not be as much as the patient had without peripapillary traction. So I feel that peripapillary traction itself is some kind of loss to the patient.
Yeah.
Yes, many of them end up with macular holes, and then no
So
matter what you do.
what I've seen is these kind of peripapillary tractions happen in two settings. When there is associated nephropathy, there seems to be a higher incidence of this kind of peripapillary traction, the retina being pulled over the disc even. Also, what you're talking about, the poor prognosis, also because very often this is associated with macular ischemia. Macular ischemia. That is why the traction, when it happens, the ischemic retina is not able to bear that and holes happen. So these are 2 points that I just like.
And Srinivas, I think if you have a vitreopapillary traction, that itself becomes an early indication for surgery. You don't have to wait for giving an
agree, but if the patient is 6 parts and you have a vitreopapillary traction and very florid NVEs in the posterior, very thick other end membrane, then I'm sure that sometimes we might burn our fingers, burn our hands.
So if in these cases, what we did was you plot out you do a field charting for them, and you find there's a large field defect with the patient having a 6.6 or 6.9 vision. And in those cases, if you go ahead and operate, you actually can convince the patient that you need an early intervention.
So my reason of presenting this young girl was she was working in this Google company and doing pretty well. And her vision, despite this florid, was 6.9. So we all know that diabetic vitrectomies may not be an easy job once you go inside and you see peel off all this or segment or delaminate all the membranes. So, and she also was very hesitant to be touched in this better eye.
I have a question for Dr. Judy. Whether these kind of patients with fibrous proliferation were included in Protocol S as a part of inclusion. Did you include? No, exclusion mentions fovea threatening TRD, but even non-foveal threatening fibrous proliferations at the arcade, and were such patients included in Protocol S for primary injection as treatment?
So the inclusion was based on investigators' discretion. So there were cases with TRD, but most of them were outside the arcades.
So because we would be very hesitant in such patients to start on a primary treatment with that.
Right.
Right, we're always worried about the crunch phenomenon.
Yeah.
I think we are getting short of time. We will quickly move on with Muna's case. Thank you so much, Dr. Lalit, for your presentation. And this is another story of Pachychoroid venous congestion. Thank you.
Yeah, can you see my slides?
Yes, please.
Thank you, Jay, for inviting me to participate in this. There have been wonderful cases so far. This patient was first seen by me in November when he came with a mild blur in the left eye vision. And his best corrected vision in the right eye was 6/12 N6 and in the left eye 6/6 N6. He had this scar just above the disc, and you see dilated choroidal vessels above and below the macula. There were a few dilated choroidal vessels in the left eye and a small pocket of subretinal fluid. This was a swept source OCT, which showed this elevated, thickened, localized area of choroidal thickening with small little vascular components. And the left eye showed a small pocket of subretinal fluid above the fovea. And this was the swept source OCT image showing features suggestive of a choroidal hemangioma with overlying pigment hyperplasia and cystic spaces. And this again was the area of the choroidal hemangioma, another area of very thickened choroid below the macula and a small amount of subretinal fluid. And you see the montage picture. This is the choroidal slab showing hugely dilated choroidal vessels above the disc and below the macula in the right eye. And this was his ICG. The fluorescein didn't add much, and in interest of time, I have not put the fluorescein angiogram pictures. The ICG shows a very, very leaky choroid And you see the wide field and ICG angiogram showing that the choroid is significantly leaky at the posterior pole. There's a little bit of dilation of the vortex, but I think this may not be very relevant. And this was the left eye again, showing a very leaky choroid at the posterior pole. Even in this area, there was no specific leak on the fluorescein angiogram to suggest that he had a CSR leak. And this was the montage, the choroidal slab showing dilated large choroidal vessels in the right eye, and you see also dilated large choroidal vessels in the area of subretinal fluid in the left eye. Now just rewind back. This was 2011 when this patient first came with blurring of vision in the right eye, a pocket of subretinal fluid, and you see this orangish mass lesion above the disc. This was leaking on fluorescein angiogram, and if you see the ICG at that time, there's an irregular tangle of vessels with intense leakage above the disc, typical of a choroidal, circumscribed choroidal hemangioma. Notice also that there is a leaky choroid at the posterior pole. This was the left eye at that time, showing a small area suspicious of a CSR leak and some pigmentary alterations, again a leaky choroid at the posterior pole. At this time, we did not have a wide field, so this is all I have of the patient. He subsequently underwent 2 sittings of transpupillary thermotherapy to the choroidal hemangioma. The subretinal fluid resolved in January 2014. He came with blurring of vision in the left eye. Fluorescein angiogram showed this point leak for which he had had laser. So to summarize, in 2011, he had 2 sittings of TTT for circumscribed choroidal hemangioma. Best corrected vision at that time was 6, 18, and 12. You see the lesion with intraretinal cystic spaces, subretinal fluid. And then in the year 2014, he had focal laser for CSCR in the left eye. And the notes subsequently say that he was stable. There were a few fundus photographs that we could find. This was the one at presentation. This was 2014. This was 2016. And in 2020, you see this hugely dilated orange choroidal vessel seen in the infratemporal quadrant. And this was the ICG angiogram in 2011 and 2020, showing that this area now has significantly increased in terms of leakage. So at this time, we were a little perplexed. There was a documented choroidal hemangioma. He obviously had pachychoroid. The choroidal thickness was around 600 in both eyes. And now he also had features of CSCR in the fellow eye. At this point, we considered the options. Unfortunately, PDT not available, and there's very little subretinal fluid, subthreshold laser, or eplerenone. After much thought, I started him on 25 milligrams eplerenone per day and suggested monthly potassium monitoring. A review 1 month and 2 months later, 2-month visit was just 2 days ago. He reported improved vision quality in the left eye, which at 6, and 6. There were increased cystic spaces in the right eye, but no subretinal fluid in either eye. This was the first visit with the small area of small pocket of subretinal fluid in the right eye, and now it's gone away. The subretinal fluid in the left eye, which has gone away and remains such after 2 months. And these are the cystic spaces in the peripapillary region, which are increasing, but his vision has remained stable. There's no subretinal fluid. And if you look in the papillomacular bundle, you see that the large choroidal vessels are appearing slightly less dilated now at 2 months. And this was the montage at 2 months. You see that the dilated choroidal vessels in the papillomacular bundle in the left eye are missing, whereas the right eye looks the same. So there are 2 references on elevated choroidal thickness and CSCR in the fellow eye of patients with a circumscribed choroidal hemangioma, and a more recent report that shows that choroidal thickness is increased and irregular in patients with circumscribed choroidal hemangioma. So just to add to the always extending pachychoroid spectrum, I now throw in, is choroidal hemangioma part of the pachychoroid spectrum? Because we know choroidal hemangioma is supposed to be a congenital hematoma that becomes symptomatic only if there is subretinal fluid. But over 10 years, we've seen now a new area of dilated choroidal vessels develop. So what exactly are we dealing with? Thank you.
Thank you so much. All right, who is taking this up? Anand?
Yeah, sure. So, I think it's fascinating and also scary that you suggest that expanding pachychoroid spectrum over the course of the last 2 hours, it's expanded like a band of elastic, actually. And
We
now,
forgot to talk about PHCR.
yes,
Yeah.
yes. So, I mean, it makes intuitive sense that if vortex vein congestion can pump up the pressures inside the choroid and lead up to the pachychoroid, this thing, any other, choroidal abnormality with a vascular connotation, such as circumscribed or even diffuse hemangioma, can perhaps raise the hemodynamic pressures within the choroidal compartment, and that may lead to this. But I don't know. I instinctively feel it may be the development de novo of a hemangioma, ascribing that to pachychoroid. I'm not sure if that is true. But on the other hand, the hemangioma may, in a patient who's predisposed to high pressure blood pressures, increase the hemodynamic pressures within, and then lead up to this kind of pachychoroid formiferous states that we might see.
So I just wanted to have two comments. The left eye, the right eye inferior lesion, which became more obvious recently, was showing some diffuse leakage in 2011 ICG as well. So probably it was pre-existing. It just became thicker and bigger eventually. And somehow in the left eye, I think that the punctate hyperfluorescence, uh, uh, are we sure to call this as CSCR? Was it like again a subtle hemangioma which was slowly leaking or oozing in that area as well? So is it like a combination of venous congestion with CSCR, or it is just a hemangioma which is just representing it from a subtle to more obvious manner?
Yeah, I have a comment to make. We had, I mean, maybe not in this case, but we had three eyes actually, where bilateral pachychoroid and a choroidal elevation at the posterior pole, and thickening and outer choroidal loculation, which all produced like a circumscribed lesion. I don't know if Dr. Munam remembers. I had presented it in Delhi Retina Meet, and it was published in Retina as a diagnostic therapeutic challenge with Dr. David Saraf and Bailey Frohn discussing, wherein it appeared like a solitary mass lesion which spontaneously resolved over 3 months time. So that was the first case that we had encountered, just infratemporal to the infratemporal arcade. So there it looked like a elevated choroidal mass. It was an elevation, and it subsource OCT showed outer choroidal hyporeflective areas. And we just observed the patient after all investigations, uveitic and metastatic and everything, nothing was found. We just observed, and after 3 months it resolved actually. So that was the first. We have 3 eyes now. It's in process of publication. So I just want, this looks more like a hemangioma to me. I'm not sure about, but I just wanted to point out that we have had patients with pachychoroid presenting.
I think the superior lesion, there's no doubt about it, because it's still showing typical features of a hemangioma on the OCT, because you see those vascular channels. Though I've seen the patient only recently, and the typical changes of hyperplasia that occur on the surface. But what was odd was the new one that was appearing. And Jay, actually the ICG of the older pictures is only of the posterior pole. If you look at the wide field ICG, you see that the leakage is almost below the arcade. So only thing is, I had not come across, do hemangiomas develop like that?
Yeah.
Or that was what was the question. And it looks quite scary actually, that area. It's quite elevated if you were to look at it in 3D.
Seeing newer hemangioma in a circumscribed lesion would be absolutely new. Any other comments, anyone?
I
One
think
question to
we are
one
still
question.
learning, still learning about Pachychoroid.
One question to Muna madam. Is it like the new lesion which you showed inferiorly?
Yeah.
Does it have all classic features of hemangioma? Because the
No,
ICG
no,
and
no, no, no. No, it
It does
doesn't.
not have.
It doesn't. It
hemangioma to
doesn't
me.
have.
That's
It
why
does
I
not.
said even our case had some atypical features
Hmm.
where elevation and observation. One case was observed, one was treated with eplerenone, and one with focal laser. That particular had at the edge of focal laser for this choroidal elevation. So maybe you could observe this patient whether before going in for further treatment.
Right now he's on eplerenone and he's tolerating it well. So I said, let's just try it for another.
Yeah, seeing the vortex vein congestion up to the ampulla could be one more interesting angle to understand the association.
Yeah.
All right. Thank you so much. Thanks, Muna ma'am, for fantastic case. I think here we finish the cases. Thanks, everyone. And now this session has two more talks by Raja and Anirudh. I invite Raja to start his talk on real world experience with Brolucizumab in India.
Thanks, Jay. I hope my slides are visible.
Yeah.
Yeah, I think we had a mini symposium on Pachychoroid. Jay, you wanted a full day symposium probably, but this one is good enough to start off. So I think my talk is slightly different. It's more about Brolucizumab. What are the experiences? And there are numerous questions around it. So it's not just about saying that my experience of X number of cases, but on most of the slides, there will be some questions as to what do we do or what are the challenges it throws up. But the biggest unmet need so far, we all know, is about the burden of the number of injections. And how Brolucizumab acts for a longer duration is because of the small molecular size or molecular weight. More number of molecules per injection can be packed into a given volume, and that's why it lasts longer. And also because of its a smaller size, it does penetrate deeper into the retina and under the RP, and all CNVMs are under the RP, and that's why it's important to understand this and see how it clinically correlates that most of the edema, if you look at the trials now, the edema reduction on OCT is much more with Brolucizumab, and that's what many of the speakers so far in India have also shown in their cases that the edema reduction or the drying effect of Brolucizumab is much more than the other molecules. Just to mention about the Hawk and Harrier trial, that more than 50% of patients were maintained on Q12 dosing even at year 1 and year 2. And that's how this Brolucizumab is useful in the sense the number of injections required or the frequency with which it has to be given is less compared to, let's say, bevacizumab, ranibizumab, or aflibercept. The other concept I would like to bring in for the discussion at the end is how do we deal with the different compartments of fluid? While the fluid study and post-hoc analysis of VIEW and CAT studies have shown that patients with subretinal fluid in fact tend to do better than those who do not have subretinal fluid, but intraretinal fluid has been shown consistently to have bad outcomes. So how do we deal with complete drying of the macula? Because the Hawk and Harrier trial showed slightly something different from what we have known about the fluid study or the post-hoc analysis from the other trials, is that patients, even with the small amount of subretinal fluid in the Hawk and Harrier trials, did worse than who had no SRF. Now, this is contrary to our earlier belief or what the data had shown. So what Hack and Harrier trial shows that you should have a completely dry macula, it's preferable. And also that if you see on the right-hand side column, the sub-RP fluid, that is also important with the data here. Typically, we have never paid much attention to sub-RP fluid as long as there is no subretinal fluid or intraretinal fluid. But from the Hawk and Harrier data, it seems that even flattening the RPE may be associated with better visual outcomes. And Brolucizumab does have a good effect on flattening the RPE. We had a survey last year for VRSI members about how whether they tolerate subretinal fluid, and 50% of the members who voted said that they would tolerate some amount of subretinal fluid, although this needs some tweaking and a better understanding. And quite a few members said that they would not tolerate any subretinal fluid. I'm going to present some cases now. This gentleman actually had come to us with very poor vision in the right eye and as well as moderate vision loss in the left eye. And he received Brolucizumab injection on 7th October. This was the pre-injection. You can see subretinal fluid, pigment epithelial detachment or sub-RP reflectivity, and also intraretinal reflectivity and subretinal shrum. And when the patient came back after a month, the vision was maintained, but you can see the flattening of the RPE as well as the subretinal fluid and intraretinal fluid have reduced significantly. But yes, it doesn't mean that one injection solves everything. These patients do have recurrence, but it's not that they get recurrence in a month. Sometimes they get recurrence after 2 months or 3 months. So after a patient got recurrence of fluid in December, this patient got an injection. Now, even after a couple of months, the OCT is flat. So should you be giving loading dose? Should you be treating and extending? These are the other questions which will come up for discussion. This is another patient who had come to us just before COVID, last year, COVID lockdown. And I'm bringing this up because we are entering in some cities again into a lockdown phase in India. And then when this patient had presented before COVID, his left eye had 20/80 vision. It had dropped to 21/25 when he came after the lockdown in October. We gave injection immediately when we saw him. And the top one is pre-injection. You see a lot of intraretinal and subretinal fluid, and also PED, sub-RP elevation. And then in November, you can see the intraretinal subretinal fluid have dried up. And in January, that is 3 months after the injection, it's still dry. And the last case that I would like to show is a patient who had received 25 Eylea aflibercept injections and had still used to have some amount of intraretinal subretinal fluid. And we decided that let's try out Brolucizumab. And within 1 day after the injection, she developed severe vitritis. There was no view of the fundus, hypopyon, and corneal folds. And this is quite unusual that within a day you get this. So obviously we had endophthalmitis in the back of our mind. There was hardly any congestion, no pain, no lid edema, nothing. It was just a quiet eye with vitritis. So we did do vitreous tap and subjected to microbiology. There was no growth, no organism on smear. PCR was negative for bacteria. And then we had also started on intensive topical steroids, and you see it just melted away the inflammation. We got back the view. The good thing to also note is that within 5 days, the Brolucizumab has had a significant impact on the macular fluid. There was almost complete drying of the macula within 5 days. But now the problem is, this was in October, November. The patient has now got back fluid, and we gave Eylea aflibercept again. It's not working, and we are not keen on repeating or re-injecting Brolucizumab. So what do we do? And in fact, this patient has had Ozurdex injection along many times to just to potentiate the anti-VEGF action. So the concerns do remain about inflammation and vasculitis. But touch wood, so far, there have been probably more than 600 procedures, maybe 700 procedures in India. We have a mechanism of tracking any adverse events, but so far as we have known, there was only this kind of adverse event, no occlusive vasculitis which has been reported so far. So with that, I stop my presentation and would be happy to take questions.
Raju, can I ask you a question here?
Yes, Dr. Rajay.
So were there any red flags for this patient when you injected? You had prior experience of injecting Paginax in other cases. So in this particular case, was there something which told you that this patient may behave like this?
No, this patient has been under treatment with me for the last more than 9 years now, and Jay would be knowing. This patient did not have any red flag signs as such. While I had injected 4 other patients probably before I injected this patient, we are always careful about patients who have had a past history of inflammation. This patient had undergone PDT earlier, in fact twice, but there were no other red flag signs in this case. In fact, she's the mother of a retina specialist. Yeah, there were no red flag signs in this case.
And now that you have seen that it's not responding to any other agents, would you, and the patient responded to steroids, so would you ever dare to inject Pagenax with a Ozurdex inside?
Are you asking whether?
Well, yeah, whether if you want to see, the patient responded to Pagenax but had inflammation. So, having known that, would you, after getting patient's consent, inject Pagenax with steroid cover?
Yeah, that's a good question. As of now, I don't have the guts, or even that retina specialist is also not keen on giving Brolucizumab again. But we are, because this patient has received aflibercept again. In fact, after aflibercept, it has increased the edema, and she has never responded to ranibizumab earlier. So we are going ahead with an Ozurdex with aflibercept at this point of time and see what the response is going to be. The last resort would be a re-injection of Brolucizumab with lots of prayers.
Yeah, I think most of these adverse events have occurred in patients who have had therapy, previous therapy. Of course, the Hawk and Harrier are treatment-naive patients. But I think most of them, at least in our experience, so there has been one occlusive vasculitis in Germany in the clinic that I consult, and the patient presented within the biblical 4-hour limit, and we were able to get back full vision. There were no residual field effects or anything. And the other patient had a macular hole. Both of them had at least had 50 to 70 injections of either ranibizumab or aflibercept. So I think that can only happen in the Western world. In India, I don't think anybody has any patients.
Yeah, I just wanted to steal a minute and ask Caroline to share her experience with Brolucizumab, because I'm sure Caroline must have used it. I haven't used so far. I had scheduled a patient, but after last year's Macular Society results, I switched her back to Eylea. Caroline, do share your experience.
Well, we have published on a collective group of patients that had occlusive retinal vasculitis from multiple centers. And then we most recently have a publication coming out in JAMA Ophthalmology looking at 172 eyes that were treated with Brolucizumab from 5 consecutive eyes from 5 retina specialists. And what I would say is we really don't understand the pathogenesis. Most of the patients, when the drug became commercially available, most of the retina physicians switched patients who were unresponsive to other agents. I mean, those really seem like the patients who need it. In our series, patients that had a mean of 20 previous injections. And I think in the majority of cases, patients might present with inflammation without vasculitis. It seems like the rate of occlusive vasculitis is about 0.5%, and that's from what we found in our retrospective series, but also what the Safety Review Committee found. That is a committee that Novartis put together to re-review the Hawk and Harrier data. So it's kind of like it appears to be a spectrum. Some patients just get a little inflammation. Some patients might have more severe, and some patients get occlusive retinal vasculitis, which is typically with inflammation. But I think it's rare, but it can lead to vision loss. So that's something that patients have to be educated about. And I will say in our retrospective series of these 172 eyes, we found that female gender was associated with occlusive vasculitis. Although it's not clear, more females are often treated, but females seem to have a higher incidence of uveitis. It's not totally clear why that is. And there were some men who did get inflammation. We also found that bilateral same-day Brolucizumab injections were associated with occlusive vasculitis. But
So-
it's perspective, so it's hard to say. And we did not find a prior history of inflammation to be associated with occlusive vasculitis in our most recent series. But it was retrospective, so it's not perfect.
So, Dr. Bamal, this patient was a female, she was a lady. So, what were the odds ratio in your study, male to female or female to male, in terms of the higher risk of inflammation?
It was a relative risk, and I can't tell you off the top of my head because there were so many numbers, but it'll be in JAMA soon. It was over 1 point something.
Okay.
Dr. Carol, I have a question. So the occlusive vasculitis, was it for the first injection or subsequent injection?
There were some patients that have had it for the first Brolucizumab injection. They'd previously been treated with other agents. And that was a paper that was in ophthalmology last year.
So did you inject any patient with vitritis or inflammation repeated with Pachychoroid or Brolucizumab the second time, or no?
If I have a patient that has inflammation to any anti-VEGF agent, I would very unlikely use that agent again. I mean, repeated inflammation's been reported after aflibercept too in some people. I would try to avoid that agent and maybe use ranibizumab, maybe reassess my thinking, why they're not responding to any anti-VEGF agent. Could there be, polypoidal or something else going on? But I would try to avoid that agent again.
Raja, one question is that you see the company label says around 4% possibility of inflammation or occlusive vasculitis. I know that in India, more than 1,000 patients have been done, and only one patient being reported as what you were saying as inflammation. I have done around 13 eyes. None has developed any inflammation and no vasculitis at all. So, and whereas all the studies show 4% chances. So,
well, I think that it's 4% inflammation. It's not 4% for occlusive vasculitis.
Yeah, inflammation.
It was 4% inflammation, 3%. I don't want to say the numbers wrong, but if you look up the safety review committee, it will say the exact numbers, but it was like 4% inflammation, then lower for inflammation with vasculitis, and then even lower for vasculitis with occlusion.
So going by those figures only, out of more than 1,000 eyes, is there any data that how many have had inflammation, Raja?
Yeah, so Lalit, I mean, it's a good question that you have. As I said, it's not a proper study that we have at this point of time. While VRSI has shared the Google Doc for everyone, all the members, saying that if you see any inflammation, do report to us. Unfortunately, it may not be very accurate, but I do believe that there are more and more people are using this drug now. And there are very few reports otherwise of inflammation. So again, whether it's because of Indian population being different or we are underreporting, there may be both. We don't know the true figure at this point of time.
I think let's spare a few questions about Indian experience for Anirudh, because he's going to share his experience on Brolucizumab for Indian data. So we can definitely come back to a few of such questions. Thank you. Thanks, Raja. Thanks, everyone. Let's move on with Anirudh's talk. We are anyway overshot.
Thank you, Jay. My presentation is visible?
Yes.
Okay. Well, I will be sharing my experience with this molecule. Although I don't have a very bad experience, so I will share the good ones. Okay, let's come to the first case. This was a 68-year-old male patient, a doctor himself. Had a complaint of blurring of vision for the last 5 months, and the vision was right eye 660 and the left eye finger counting 2 feet. Dilated fundus examination showed a bilateral CNVM, and you can see the OCT, the right eye active CNVM with the central macular thickness 341. The left eye was also an CNVM. Obviously, prognostically, this eye was not that good, and the CMT was 421. So this was the time, actually a week back, the Brolucizumab was launched, and we planned for the left eye accentrics. On the right eye, I had given an option of aflibercept and Brolucizumab. And this patient, being a doctor, went on through the pros and cons, and he actually went through the studies as well. And he decided to take Brolucizumab, and I was also very keen to see what the effect of this new medicine. Lucky for the patient, lucky for me, after a month of the first dose of Paganax in the right eye and the left eye accentrics, you can see it's responded pretty well. In fact, the vision also improved from 660 to 636. And the left eye, as I said, it was not prognostically well. The SRF, obviously, the fluids dried up. The vision didn't change much with injection of accentrics. And as we have seen in Hawk and Harrier, the loading dose, I followed the same sequence. So this patient was given 3 loading dose. This is the picture after the second dose, almost complete resolution of the membrane. And this is after the third dose. And the vision improved to even farther 618. And in fact, the patient was so happy that he insisted me to give Paganax in the other eye as well. Although it didn't show any changes anatomically, but somehow the patient was symptomatically better in the other eye as well. So this, if we summarize the first case, it was a treatment-naive patient with 3 doses of Paganax actually improved from 660 to 618. And already 1 month we have seen in the follow-up, he is doing fine. Coming to the second case, this was a 56-year-old female patient, dimness of vision in the right eye for a week's time. And it showed a subretinal bleed, and most likely it was an IPCV bleed. I can see the thumb-like PED and the subretinal bleed. And this, by this time, I have already given 2 Paganax and planned injection Paganax for this patient. This patient was an outstation patient, so I was, this time the Dr. Rajas came up, and there was a lot of discussion. I was very concerned about this patient, so I actually had seen this patient twice in the first week. And in the first week when she came, I thought, let me do an OCT and see what is the response. To my surprise, and within a week's time, it responded pretty well, and the patient from finger counting close to face actually had started seeing something like 1/60 vision had already come. And this patient, when came after a month's time, the vision improved to 660. And we decided for the second one. You can see after the second one, the vision further improved to 636. PD has decreased, and patient is symptomatically much better. And in fact, we have given the third dose to this patient. So if you summarize the second phase, this was also a treatment-naive patient. IPCV bleed, responded pretty well with 3 injections of Paganax. Third case was left eye CNVM or an IPCV. I will come to it why I have put oblique IPCV. This on presentation on 9th of June. This was the lesion, and he had undergone 3 loading doses of accentrics and responded pretty well. And the vision also improved to 618. The problem came after 6 weeks after the follow-up of third dose. That is, you can see here we have a notched PED. So most likely it might be a PCV lesion. That was a COVID time, so we were not doing an angiogram routinely. But definitely this lesion shows that it might be a PCV. And by this time, I have used quite many Paganax and was quite confident. And we have given injection to this patient and responded pretty well, and in a quick time actually. This was after 4 weeks, but patient actually responded pretty early than 4 weeks. Patient was symptomatically much better. So this was the third case. Summarizing this, this was a recurrence after the 3 doses of accentrics, and following that 1 dose of Paganax improved to 612. Fourth case was similar to the last one. Here, the left eye had received 3 doses of Eylea, and the other eye was also a CNVM, but scarred CNVM, but received 1 dose of accentrics. This was at presentation. And after 3 doses of Eylea, you can see the lesion is responded pretty well. The vision also improved. But here also the similar story. After 6 weeks, there was again a recurrence, and the vision dropped down to 660. And after giving single dose of Paganex 612, already this patient has, we are following up for more than 2 months, still maintaining, and there is no reactivation of the lesion. So this is the summary of the 4th case. This was a recurrence after 3 doses of aflibercept, and then we gave the Paganex and responded well. Coming to the last case, 78-year-old male patient, dimness of vision in both the eyes. Right eye was diagnosed with active CNVM. Left eye was a scarred CNVM. This patient actually was following with me for a long time, and he was getting the injection aflibercept, responding, but again after 4 to 6 weeks, some amount of fluid was coming. So you can say it was some sort of a refractory case. And after the 7 dose, I thought I will change the medicine and let's see what Brolucizumab do in this patient. And actually, it responded pretty well as far as the vision is concerned. Still, a little bit of fluid is there. So this is the entire list of my Paganex patients. Till date, I've given 20 injections. 3 of that is a treatment knife. In all the patients, actually, it responded pretty well. Coming to the Indian experience, like Dr. Lalit was mentioning, now more than 1,000 patients has already got this injections, and only 1 case adverse report has been reported. And most of the indication is obviously AMD, but there are some off-label use in PCV, as I have already shown some cases of PCV, as well as in DME and CRVO as well. So coming to the take-home message, okay, it actually responded pretty well in all the cases, and the good part is it actually addressed all types of fluid: the intraretinal, subretinal, sub-RP, central macular thickness. And lucky for the patient and lucky for me, no patient actually showed any signs of postoperative inflammation, whether it's anterior segment or a posterior segment vasculitis. Obviously, it is too early to say, but time will say whether this new molecule, Paganex or Brolucizumab, is safe and the most effective drug in the treatment of wet AMD and PCV. Thank you.
Thanks, Anirudh. It was really nice, and I'm very happy that
I think this drug showing all the good results we have shown. None of your patients had any adverse event at all.
Right.
So does this become number 1 choice for you?
Frankly speaking, those who can afford, I'm giving this medicine as a first-line choice. Although I give option all the anti-VEGF option, but seeing the effect and the way the medicine is working so fast, and the durability is also pretty good. So it has become my first line, at least until I get some adverse events.
I have a question. Do you take a informed consent about the 4% inflammation and 1% occlusive vasculitis? That's my question.
Actually, we are planning to put that in the consent form. Till date, we didn't have it. Although I explain whenever we are using these medicines, I do explain the pros and cons of this new molecule.
Because as an institute, we have decided that if a consultant is using, it should be with an informed consent, because if in case of any kind of litigation comes, like it is not an informed, that it is very well available. If you type in the Google, it's very well available.
Yeah.
So I think an informed consent is extremely important, and since
I
it's
think
1,000 injections, I would like to know how many of those 1,000 are single injections, how many have crossed 3 to 4 injections, because I learned that most of this inflammation happened after the third or
injection.
After the third injections.
Yeah,
I
because
have multiple injection in 2 of my patients, 1 3 injections, and another the first patients actually got 3 injection in 1 eye and 2 injection in the other eye as well.
See, George, the other thing is
not there how many is actually having multiple and how many are having only single injections.
One thing I agree is that the rapidity of onset is there. You see, because within 2 weeks, it does show an effect. So this is one of my patients. You see, where I had given this, and you see, my perception is that patients who have PED with fluid symptomatic, they seem to respond the best, rather than the classic CNVM picture.
I think Hawk and Harrier study also mentions the same thing, that sub-RP fluid responds better with this new molecule compared
Yeah,
to.
whenever you see, I have seen positive response. It is the RPED, or like you're saying PCV with the fluid. This patient responded within 10 days, in fact.
I think that is why it's been shown to be non-inferior to aflibercept. So I think that was the main criteria, and the main thing is that this is the type 3 hypersensitivity response.
Yeah.
So being a type 3 is not obviously going to happen with the naive patients. And other thing, as what George said about the consent, the problem is in the consent we have to say what options are available to the patients. So once we tell them that you have an option of Eylea or something else, and you tell them that this drug causes occlusive vasculitis, then how do you handle these patients? That's what I want to ask Anirudh.
No, actually, this has happened with me. This patient was also a physician, and I explained that there is a side effect of vasculitis. Actually, he refused to take it. So
I wanted to ask that, did you experience, aside the chances of inflammation and vasculitis, did you experience actual increase in treatment-free interval in some of your patients which were being treated before?
When I have used in the refractory case or a recurrent case, I already the time frame has gone near about 3 months, and they are maintaining pretty good. Like almost 2.5 months has passed away, and still the lesion is bright.
Okay.
My thoughts on this is that, I mean, we have no doubt that it is efficacious. It's only about the safety issue. One thing which I'd like to point out is that, all the other drugs, the molarity is about 1 to 1.5 to 1.5. But this one has many times that. And it's something which the, Novartis and others actually pump up as an advantage, that we are giving so much more of the drug. Now, I think if a drug is supposed to be more efficacious, then less of the drug should be equally efficacious. You should have 1:1 modality. You're putting that much more drug.
But in Hawking area, I think 3 milligram didn't perform that well compared to the 6 milligram.
Yeah, correct. So that is the paradox. So you're giving that much more of the active drug into the eye. Also, the most important thing is difference from the others is this is the only drug which is using a biosynthetic polymer, a scaffold. So in a way, there's a lot more plastic which you're putting into the eye, even if it's biodegradable. So perhaps nobody knows whether that's related or not, but it could be that somebody has an allergic reaction to that scaffolding and not the drug per se. So that's a moot point. There's something to think about.
So indirectly, Anand, you're saying if you increase the molarity of other drugs, similarly, they may be as effective as this particular agent?
That is to be seen. I don't think at least with Avastin and with Adisba, when they increased the dose, it wasn't seen to be that effective. This one's the dynamics is different. There's no doubt about that. It's more just like aflibercept shows PD flattening more than Avastin and Ranibizumab. This one does more, perhaps Eylea. But what I'm trying to say is that this is the only one which has the scaffold biosynthetic polymer going into the eye, and that many more times because the molarity is so high. So whether that it's a debatable thing, but it's something to think about.
Yeah. To what Anand said, even they are looking at that actually, whether increased dose of the drug inside is, they are looking into that. So they are thinking whether these loading doses can be avoided, can be started from less, intense dosing.
Actually, it's a smaller molecule, 28 kilodaltons. So I think that obviously has helped them to increase the molarity.
So I think almost done and out of time. I think Jay had to leave. So I think on his behalf, I think I'll thank everybody for a fantastic session. Thank you, everybody. It's been a wonderful session. And thank you to AIOS and APBRS and IOC for putting this up together. Thank you very much.
Thank you. Bye-bye. Thank you.
Thank you, everybody.
Bye, everybody.
Bye.